My name is Marnie Brown, and I'm the Marketing and Communications Manager in the U.S. for Scandidos. I want to thank you for taking the time to attend the webinar this morning. Our hope is to provide you with a little bit of insight from the clinical application for our Delta4 Phantom Plus, which received FDA approval in 2016. We're excited to have a guest speaker today, and joining us to share some insight on his daily clinical use of the Phantom Plus is Michael Butkus. He's the Chief Resident of Medical Physics from Yale University School of Medicine and Yale New Haven Hospital. The presentation will take about 30 minutes and you will be in listen-only mode. We are recording the session. We will open for questions at the end, and you may also submit questions at the bottom of your screen during the presentation in the question box. So with no further ado, Michael, please go ahead and start the presentation. Thank you.
All right, thank you, and thanks for attending today. As Marnie said, I'll just be giving a quick outline of the use of the Delta4 Phantoms for patient-specific QA in the clinic. So let me figure this out real quick. All right. So to do that, as a quick outline, I'll first discuss the rationale of patient-specific QA and why we care about 3D patient QA especially. Talk about the current methods we do use for QA. That'll introduce us to the Delta4 family of Phantoms. I'll describe their physical and detector characteristics, and then talk about the major differences between the new Delta4 Plus Phantom and the older Delta4 that some people may be more accustomed to. I'll quickly go over the usage of it at our clinic, and then I'll just go through a really quick sample workflow of what a clinic could be, or what they could expect to do if they acquired one of these units. So the rationale for 3D patient-specific QA, we have to do it because as the complexity of our treatment planning and beam delivery keep becoming more and more complex and individualized, we're introducing a lot higher uncertainties that the dose we plan will not exactly match the dose we impinge upon a patient. One of the ways to reduce these uncertainties is to measure the delivered dose before a patient begins treatment, and these measurements, of course, have become the standard of care for all IMRT and VMAT treatments. The optimal detector to use would be able to characterize the delivered dose in 3D space and relate this to the actual planned dose. And as an added bonus, if a plan did fail, we would like the detector system to be able to give us a way to kind of find the root cause of this failure. With these simple, straightforward goals in mind, let's take a quick view at some of the patient-specific QA systems that are currently being used. This list kind of orders from least complex to most complex, I guess. The least optimal independent check would, of course, be a hand calc or an MU calc. These methods do not check the deliverability of the beam, for one, and they're generally less accurate than your TPS system. We move on to just the point detectors. Although these can provide you with a highly accurate absolute dose, they yield no information about the dose distribution. 2D dimensional methods, they're perhaps the most commonly used in clinic. They're detector arrays or EPID, film, there's a lot of options. These all suffer from the simple fact that it's difficult to relate errors in these measurements to relevant 3D distributions. The next class of detectors would be the simulated 3D detectors. This includes the Delta4. These detectors measure dose in multiple planes and use this dose to calculate dose in regions of Phantom where there is no detectors, so it's able to reconstruct and simulate a delivered 3D dose. And since true 3D detectors such as fickle gels have not been found to be practical in the clinical setting, detectors such as the Delta4 represent the highest sophistication of Phantoms that are being used for patient-specific QA. So with that said, let's introduce you to the Delta4 Phantom a little bit. The physical characteristics of it: it's a 22 cm cylindrical, or 22 by 40 cylindrical piece of plastic. It's it can be constructed of PMMA or plastic water. The PMMA model is the more common one and has a relative electron densities and bulk densities of 1.19 and 1.14 respectively. These dimensions are equivalent for both models, whichever one you buy, the PMMA or plastic water, and are equivalent between the old Phantom and the new Delta4 Plus Phantom. Each Phantom is quartered to allow for insertion of 2 planes of diode arrays, and then there's also just leveling legs and external markings that allow for easy alignment in 6 dimensions. That's just the physical characteristics of it. The true utility of the detectors is in its diode arrays, and it has 2 20 by 20 cm detection diode planes. In total, there's 169 p-type silicon diodes. In the central portion of the arrays, the central 6 by 6 cm, there's a 5 millimeter resolution of the diodes. Outside of that, there's a 10 millimeter resolution of the diodes. And you can actually increase this resolution in the middle by taking multiple measurements, and you can reconstruct down to a 2.5 millimeter resolution. The diodes themselves have shown very high linearity and consistency over a wide range of measurement parameters. Listed down below here are some of the parameters. The ones that show the greatest deviance are the temperature and angular dependence. These are, however, corrected for in the software. The angular dependence is naturally corrected for. You don't have to do anything to it. The vendor adjusts for that. Temperature sensitivity you do have to adjust for, but this is as simple as just plugging in a temperature reading every day. So up until now, I've described the Delta4 and the newer Delta4 Plus as the same model pretty much, but there are some major differences between them. The most notable differences among the 2 Phantoms is the lack of external wires in the Phantom Plus model. I'll show an image of this later on, but the reduction of wires greatly decreases the setup time and just makes the flow of the entire measurement process much simpler. The older model required external connections to power the device, to transfer data, and to sync to the accelerator poles, so 3 cords in all. Power is now supplied by a rechargeable battery. This battery has an approximate life of about 4 hours. Data is transferred wirelessly, and the sync is now under automatic control. All these steps save time. An additional time saving is when setting up, you don't have to let the electrometer or detectors equilibrate anymore. They're ready to go as soon as they're plugged in. And that step by itself saves about 15 minutes of time. The orientation of the detectors has also changed. Previously, they were X-shaped, either 40 to 50 cms from the cardinal directions. Now they are aligned in the cardinal directions and form a plus shape and give the Phantom its new name. One of the reasons for changing this was to allow for easier measurements of spinal fields. But in our clinic, it's had the added benefit of it's just a lot easier to understand the dose distributions in these 2 planes instead of a rotated plane. The diodes themselves are also much more stable in the new Phantom. They do not require relative recalibrations over the lifetime, and the recalibration you do have to do once a year is much simpler. I'll get more into these later, but it's just a lot less maintenance. Lastly, the ability of the Phantom to measure FFF beams have been improved. In the older Phantom, it was kind of intermittent. It would work on some people's FFF beams, not on some other people's FFF beams. The new one, we've had no problems with it, and I've heard of no other clinics having a problem with it with FFF dose rates. I'd like to add that despite all these differences, the software and the user interface between the two models is exactly identical. So if you do upgrade and you were already a Delta4 user, there is no learning curve at all on using the new model. I know this because at Yale we did recently upgrade to the Phantom Plus model. We began ramping up our usage of Delta4 after an installation of the new Versa HD, which began VMAT treatments the start of this year. We've exclusively used Delta4 to run QA on this machine. We initially ran 54 plans with the old model and then upgraded to the new model and have ran 81 plans now. So we've had quite a bit of experience with both the old and the new detector in the last year. We also now use the Delta4 Plus Phantom for all of our FFF treatments, and it serves as a backup for 3 other accelerators. In all, it's accounted for roughly 150 or so QAs we've ran this year. And in grad school, I also used this machine quite a bit for over 2.5 years. So I've become quite familiar with it, and I can attest that the new model, at least, it works a lot better than the old one. They improved it well. Since I do have quite a bit of experience on it, I'll just give a very general workflow of what a clinic would expect to do with one of these Phantoms and the timelines that work with it takes. The first steps when you first get it, the preclinical steps, you have to configure and calibrate and create a Phantom. In total, this takes about 2 hours for a new Phantom, and then you can add on about 40 minutes per linac you want to calibrate it with. These are steps that are only done once, so it's a little bit of a investment at the start, not much, but after you do it once, you don't have to do it again. To actually run the patient-specific QA every day, I'd say it takes 12 to 15 minutes, depending on your clinic. You create a plan, export it. It takes, I'd say, roughly 5 minutes to set up the Phantom, and then after that, it's just delivery time, and the analysis is automatically done right after the plan is ran. And of course, I've got a minute listed here. I'd recommend spending more than a minute analyzing it, but the results are given to you immediately. Additional maintenance, yearly you have to do an absolute calibration, and for a 5 energy machine that takes about 40 minutes. So not that much time has to be devoted to maintaining the system, which is nice. So I'll just quickly walk you through each of those steps real quick. In the preclinical steps, the first step when getting this Phantom would be calibration. The initial installation of the software and the calibration is done by a ScandiDos representative, so it's not overly taxing on the physicists, and there's not much confusion on trying to configure the software right because someone who's experienced in it is teaching you how to do it. The first 2 steps of the calibration, a relative and a directional calibration, they have to be done with the Phantom disassembled, so there can be a flat profile. This disassembly and subsequent reassembly are really the only difficult parts of the calibration, I'd say. And with the stability of the new generation of diodes, it only has to be done once, the initial time. The rest of the calibrations is really just following a cookbook. It's simple instructions. So these first 2 steps, the relative calibration, that just characterizes the response of each diode. It involves an irradiation in 7 different setups. The directional calibration, it's not for the directional dependence of diodes. That's already accounted for by ScandiDos and software. This is just for differences in dose caused by the actual physical construction of the detector board and the electronics. The reference and absolute calibration, and this cavity has fits for several different common ion chambers, a farmer chamber, and many other more models. So I would imagine whatever you use for your absolute calibration on other machines, there's a cavity hole for it available from ScandiDos. And this step just really boils down to irradiating at different field sizes for all energies with the ion chamber inserted to get an absolute reading, and then irradiating at different gantry angles and relating that reading to the diode reading. So it's a pretty simple process, takes 30 to 40 minutes each machine. Of course, you should always verify these measurements with some plans afterwards. So after the calibration, you also, before you go clinical, you have to create a phantom. This step really couldn't be easier, as ScandiDos provides you with phantom sets for both PMA and solid water, and they provide them at whatever thickness you need your reconstruction to be at. If you wish, you can scan your own phantom to get clinical specific HU numbers, ones that are relevant to your actual CT curves. We did do this at Yale. The one little warning is when you do scan it, you will get some artifacts from the high density arrays in the middle. So to get around this, you can just scan it, find a characteristic region that gives you your actual HU reading, and just apply a density override to the whole phantom with this HU reading. Doing this, we only had a difference of about 5 HU from what ScandiDos naturally gave us, so it doesn't really make much of a difference, but we felt a little safer looking into it ourselves. After that, you're pretty much ready to go. Planning is simple. You create it like you create any verification plan. You're just taking the delivered dose and projecting it onto something that's different than the patient's body. The software is compatible with any planning systems that can export DICOM RT plans and RT doses and RT structures. The structure is not a necessity, but it's a nice added feature that the software does provide. A couple little notes when you're planning. Whatever your dose calculation grid size is in your planning system, that is the grid size that 3D dose will be reconstructed at in the Delta4 Phantom. And whenever you, in some plans it might be necessary to apply a shift to the Phantom. When you are applying this shift, you have to remember to notify, after you import the plan into the software, you have to notify them that there's a shift. It makes sense after you do it, but it's not always intrinsic the first couple plans you do, or if someone without much experience is running the software. So yeah, you plan, you export it, you import it into the Delta4 database. Then you have to set up the Phantom. Setup is pretty easy. The device is on a trolley, so you never have to lift it. It just glides over the table, which is nice considering it does weigh nearly 60 pounds. It would be a burdensome device if you did have to lift it. There are markings on the Phantom to align the lasers and crosshairs, and legs to help adjust against the table sag. We did initially CT scan it, and the external markings do correspond very well within 0.1 millimeters, I would say, to the external markings match the actual location of the internal arrays, so you can really trust those markings. There's also an additional inclometer you can attach to the gantry to measure the actual gantry angle. This is not necessary to run a plan, but it will help the software obtain slightly more accurate results when it's trying to reconstruct a 3D dose if it knows exactly where the gantry is. Lastly, with the new Phantom, you should double check the wireless connection, I would say. On our first model of it, we did have some initial connectivity issues. We notified ScandiDos, and real quick they sent us some new electronics, and since then it's worked fantastic. So just some pictures of the setup. You can see here the trolley also functions as a storage cart. So everything's just located in one location, real easy. Roll it around the clinic. On the right, you can see the differences between the old and the new Phantoms. The old Phantom, you got wires coming everywhere, an electrometer not connected to the machine. This new one, it's just really clean, really easy, efficient. It's a lot nicer, I'd say. So once you set it up, there's a couple steps you can do. You can correct for your machine's output. I rarely do this because I find it a more robust measurement of the test if it can pass without adjusting for daily output fluctuations. But if you really do just want to characterize the accuracy of your MLCs or anything like that, you should use the daily correction. To do this, you just run a simple open field plan, and the average difference between the planned and measured dose is used as a scaling factor. I use a 20 by 20 open arc when I do this, just so it gets every detector from every angle. Like I said earlier too, the pressure or temperature sensitivity is about 0.4 per degree, so you really should measure the temperature every day in your room. I've seen a lot of clinics just plug in like a generic room temperature, 22 degrees or something, and they're always curious why their measurements are off by, 4 or 5% or something, and this actually does explain it. When you're actually taking the measurement, the diodes are sampled every pulse of your detector and then cleared, and then later these pulses are integrated together to get your total dose. This has several benefits. Since dose is cleared, there's no worry about saturation of the diodes, so you can run, any SBRT or really high MU plan with these without the worry of saturation. Also, since there's no sampling between the dose pulses, noise is reduced, but probably the greatest benefit of it is it allows for binning based on your gantry angle, and then you can reconstruct the dose in 3D after that. During this sampling, the directional dependence of diodes is automatically accounted for, and it's based on your current gantry angle. This is where use of the inclometer helps. It can tell you your true gantry angle, or Delta4 can assume the gantry angle from the fractional amount of MUs delivered. We always do the fractional MU way and haven't seen any problems. We might be able to get a little bit better results with the inclometer, and I know a lot of clinics do use that. I personally can't attest to it though. And that's really the entire process for a single measurement. Couple things I should add. If your field size is greater than 20 cm, which is the length of the arrays, you can run 2 shifted measurements and the software automatically merges them together. And by this same process, you can increase the resolution in that central region to 2.5 millimeters, which for diode or ion arrays is quite small. Immediately after the measurement, 3D dose throughout the Phantom is automatically calculated through ray scaling, and dose statistics are also calculated. A fairly standard set of analysis criteria are calculated, such as dose deviation, distance to agreement, gamma indices, and DVHs. Visual inspections of profiles and isodose matching can also be done. I should note that the overall passing criteria is set by the user and can be changed at any time, and it can also be applied to the total plan or individual beams or even angular segments. The physicist in charge really should spend a little bit of time thinking about what these passing criteria should be. dependent on what you normalize to. If you want to base your dose on the ISO center, the maximum dose delivered, your prescribed dose, it can really change the results of some plans. And it's just, without a good understanding of it, it's hard to relate the parameters to other people in your clinic. So you should spend a little bit of time looking into that. And it can always be changed later on. You can compare the results doing it different ways. So yeah, analysis is quite quick and very easy to work with. This is just a couple of screenshots so you can see the analysis interface. These are from a head and neck patient we recently measured. In the top left here, you can just see that each of these 4 arcs passed by the little green beam. The passing criteria was set at 2% 2 millimeters. It's a global gamma, and we were normalizing that to the maximum dose in the arrays. Below that is just a setup of the orientation of the phantoms. This is actually surprisingly helpful for most people, because when you're applying shifts to the phantom, it actually shows where the laser shifts on the phantom, so it's just a healthy little double check that people can use. In the center and top right here are the measured doses in each detector plane, and there are some contours overlaid on these images as well. These views can be toggled to show the 3D dose as well as axial, sagittal, and coronal dose slices. And other calculated matrices could be shown, gamma or relative differences, distance to agreement, whatever you want. Below are histograms for dose deviation, distance to agreement, and gamma rate. The yellow bars inside these blue bars are for diodes that are just in this region of interest. So there's a lot you can manipulate with. You can get quite a bit of information out of these screens. Just another picture of one of these analysis windows. These views are for the same patient, but just for the first arc. The lower left gives some of the beam settings, which is also a nice feature just to double check the plan while it's running. The diode planes show the gamma values this time, blue for passing, red for failing diodes. Below are the measured profiles overlapping one another, very good agreement between the two, and the green dots are the actual gamma passing rate, as you can see on the right-hand axis there. So that's just a very general introduction to it and some of the analysis tools. There are some higher fidelity uses that are really helpful. 2 of the major ones are the MLC leaf movement calculator. This just helps show where dose deviations are, and they correspond back to your MLC file, and if dose is a little too high coming below one of those leaves, it might mean the leaf's too far open. If it's too low, it might mean the leaf's too far closed. And this is just a really helpful tool to see why a diode might be failing and to go back, look at your MLCs, see if it actually is because of that. And we've had pretty good results with this, actually corresponding what Delta4 tells us might be wrong and showing that that is actually what is wrong with our MLCs at that point. Another very helpful tool, and there'll be another seminar on this later on, so I will not really go into depth at all on it, is the deviation anatomy tool. This tool, it just takes the structure set from your patient, impinges it on the phantom, recalculates what the DVH would be for that organ on the phantom, and compares the measured DVH to the calculated DVH. So you can, instead of just looking at an entire plan, you can look at specifically how the passing rate in the spine looks, or the heart looks, or the PTV, whatever you're interested in. And it just, lots of times when an entire plan pass, maybe just the spinal cord is getting too high of a dose, and that's what you would actually care the most about. So you can it just gives you more options of how to analyze and look at exactly what you want. So in summary, the Delta4, it allows for accurate dose measurements in very stable diodes, and it allows for reconstruction of 3D dose throughout the phantom. This reconstruction is what allows for uses of that DVH I was just talking about. The temporal sampling of the data allows for segment-by-segment dose reconstruction, and the intuitive software allows for immediate and easy analysis of the results. The new Phantom Plus model is a much cleaner system than the older model, and it allows for easier setup by eliminating external wires, and it has worked in our clinic for all our FFF beams. And use of the new Phantom will also reduce your overhead time by reducing the need for recalibrations. So that's just a quick introduction to the system. If you have any questions, I can field those now.
I will be opening it up for questions and unmuting. So if you have any questions, please go ahead and take the time to ask Michael. Everyone is unmuted. I do have a quick question while we're waiting in case anyone else wants to hop in after. But Michael, yes, or you did kind of mention during your presentation the comparison between the Delta4 Phantom and the Phantom Plus and the time savings and such. But I'm wondering, a complete overview, if you could tell me sort of what was your decision making with respect to upgrading from the Delta4 to the Phantom Plus. What were maybe the main reasons?
Well, one of the main reasons was another one of our clinics needed the use of Delta4, so we needed two, so we bought a new one. Just, I guess that's a real reason why we bought it, but what you would like answered there, I believe, is what benefits have we found from it? Right. Compared to the old one now, and it really is just the time saving is the biggest part. Not having to roll out cords, being able to just pretty much set it on the table and go right away, and not having problems in the connectivity has been quite nice. The older Phantom, we also did recalibrate it probably twice a year. And that would be a weekend job, coming in on a Saturday and doing it for every machine, taking it apart, putting it back together. And now we haven't even recalibrated the new unit. We've had it for about 7 months now, and the calibration is holding really constant for all our machines. So the lack of having to recalibrate has been a real time saving for us too.
Great. Thank you. Does anyone else have any questions?
All right then.
Okay. Thank you so much, Michael. We really appreciate your time.
Thank you.
Absolutely.
Have a good day, everybody.
Bye-bye.